symptoms among general population. My name is Vijaya Sher, and I'm from Fatma Jana University, and my supervisor in this study was Dr. Saj Danaz. First of all, I will be talking about the abstract of the study, in which basically I had 340 COVID-infected individuals. That was my sample size, among which 198 were males and 142 were females. The study was cross-sectional and quantitative in nature, and I will be talking about the findings of the study further on when I discuss the results. First of all, to introduce the topic, COVID is, as we already know, it is a viral disease, and it is caused by a newer strain of coronavirus, and it has infected over millions of people around the whole world. And then talking about COVID-related stigma. Stigma is used to describe, the term stigma is used to describe the phenomena of negative discrimination against people who have certain aspects, such as behavioral aspects or social attributes. And when it comes to COVID-related stigma, of course, as the term already explains, it is stigma which is associated with COVID, or people who have had COVID because of the novelty of the disease, and not much is known about it. In terms of mental health challenges, in terms of this study in particular, I will be only discussing anxiety and depression. That's what I measured with my assessment tools in this study. Moving on to the objectives of the study, the first objective was to assess the levels of COVID-related stigma and associated mental health challenges among the general population, which was operationally defined as COVID-infected individuals. Then I will be talking about the correlation between COVID-related stigma and anxiety and depression among the general population. Further on, I have also assessed the gender differences and age differences in terms of those variables as well. Moving on to the instruments which were used in this study were information sheet, informed consent, demographics, and COVID-related profile, in which I basically asked about the age of the participants, whether they had been infected with COVID, or if they had been vaccinated or not. Then moving on to the assessment tools, I used Stigma questionnaire and generalized anxiety disorder scale and patient health questionnaire. Coming on to the research methodology, the design, as I've already mentioned, it was quantitative in nature, and it was the cross-sectional correlational study. The settings, the study was set online, it was conducted online, and the questionnaire was circulated through different social media platforms. Sampling was convenient sampling strategy, and the total sample size was 340. The participants, their age ranged from 18 to 65 years old, and I specifically included individuals who had contracted COVID, and I included individuals from all over the country and not just one province or one city or a couple of cities. And the number of male participants, as I've already mentioned, there were 198, and female participants were 142. Coming to the inclusion criteria, individuals which were aged 18 and above, who had contracted COVID and who had a good understanding of the English language in order to fill out the assessment tool, and then also who provided their informed consent to be included in the study. Coming to the exclusion criteria, people who did not have COVID were omitted from the study because there were certain participants who did say that they did not have contracted COVID, so they were omitted. And then people who had certain mental conditions, they were also not included in the study. Now, moving on to the results, finally. This is a table which shows demographic statistics and descriptive statistics of demographic variables, including the age, level of education, the province they were from, and COVID-related profile, in which if they had been infected with coronavirus, if they had recovered completely, or if they had gotten vaccinated or not. This is the assessment of stigma in different in terms of different types of stigma which were measured in the assessment tool, and they have been broken down into male, female, and then total categories, and their range has also been shown. Looking at the results, we can see that inactive stigma has the highest mean, and then perceived external stigma in this study, and they had a higher score compared to other stigma, which was disclosure concern and internalized stigma. Then moving on to the assessment of levels of anxiety among both the genders, and the results significantly showed that there was significantly higher level of severe level of anxiety among females rather than males. Then again, levels of depression were also measured and broken down into male and female categories, and it is depicted in the results that the severe level of anxiety were also, as I've already mentioned with anxiety, depression was also more prevalent in females rather than males. Now, the main correlations which was run between COVID-related stigma and mental health challenges. So it was found that COVID-related stigma had a very high level of correlation between mental health challenges, which were anxiety and depression, with perceived external stigma having the most, the most positive and significant correlation between anxiety and depression. Then at the end, it is gender differences among COVID-related stigma, gender differences among COVID-related stigma and anxiety and depression, and it is also, and it is shown by the testing that was run that the external, the stigma seemed to be more prevalent in females rather than males, and there was a significant gender differences among both the mental health challenges and the stigma. Then coming on to the age differences, as I didn't really mention it in the abstract because there were not really significant age differences among any of the variables that were taken in the study. And finally, the limitations and recommendations. The parameters, I guess one of the limitations was that full recovery status was not really specified. There was no option for people who had not good proficiency over the English language, and also the fact that not equal number of data was not collected from people from all the age categories or from all the provinces as well. And then recommendations, few recommendations that were added to the study was that future researchers should specify the recovery period and also find a way to, I guess, incorporate the uneducated people or illiterate population in the study as well. And to conclude this entire study, there was a presence of COVID-related stigma in individuals who had contracted COVID. There was prevalence of levels of symptoms of anxiety and depression ranging from mild to severe, and significant positive relation was found between COVID-related stigma and associated mental health challenges among the general population. There was a clear indication of significant difference across genders in the mental health challenges associated with COVID-related stigma, and severe levels of anxiety and depression were found to be more prevalent in females rather than males. And again, no significant difference was found between the variables in terms of age differences. That's all from my side.
Thank you very much, Ms. Wajiha, for presenting such a wonderful paper on the stigmas that are attached with the mental health,
Thank you, ma'am, for having me
during the COVID-19. So kindly stop sharing your screen, and the next presenter who will want to present today on psychological predictors, Ms. Medhat Fareen. Ms. Medhat Fareen.
Thank you. Thank you. Thank you for.
Okay.
So I'm going to share my screen now, and just.
Ms. Medhat Fareen will going to present on the psychological predictors of the quality of life among the patients with the hypothyroidism, a cross-sectional study in Rawalpindi, Pakistan. Over to you, Medhat.
Thank you so much, Ms. Sana, and to Fatma Jana for giving me this opportunity to present this topic. And just to clarify, this study was not just conducted by myself, but a number of other researchers also contributed and conducted this study. But because of unavailability of and some other factors, I'll be presenting the findings of this study on behalf of the whole team. So the topic, as already mentioned, is psychological predictors of quality of life among patients with hypothyroidism. And this was a cross-sectional study which was conducted in Rawalpindi over a duration of time. As stated earlier, it was conducted by Major Nazir Mustafa, Dr. Iram Gul, who is from Fatma Jana University, myself, Dr. Adila Rahman, who is the head of Department of Sociology at Fatma Jana, Mr. Fahad Halim, and Mr. Gul Hussain. Just to give a brief introduction about the topic. So hypothyroidism is one of the endocrine disorders, and these are increasing globally for some time now. And according to World Health Organization, thyroid-related disorders are affecting mostly, we are at most 750 million people around the world at this time. And this was the previous statistic. So if we can take this as an example, the numbers are much higher now. And in Pakistan, again, this is a previous study, but in Pakistan, there is again around 41 to 5.4% prevalence of hypothyroidism and subclinical hypothyroidism, and mostly the reported cases are in females. So the prevalence and patterns of thyroid disorders depend upon various factors. It could be geographical, related to geographical factors, environmental conditions, and especially their eating habits and lifestyle. So lifestyle has an important factor to play, not only in the occurrence of the disorder, but also in the management of the disorder. And we'll see how it affects the overall quality of life later on. So because it is a chronic illness, and we know that judging from the experience from other chronic illnesses like hypertension, diabetes, and cardiovascular diseases, the research has already supported that these chronic illnesses does impact the quality of life of the patient. And because these diseases require constant management and, you know, changes to have to be made in your overall lifestyle. So that's why it poses a burden on the overall quality of life of person. And it has been seen in the previous research that the quality of life of people who are suffering from such diseases is not up to the par, or they are living with a low quality of life. So that was basically one of the reasons why we thought about, you know, exploring the quality of life of patients with hypothyroidism. So the rationale, as I've already stated, that literature has found that there is prevalence of hypothyroidism in Pakistan, but there are very limited studies who have already studied the psychosocial aspects that relate to the quality of life or overall well-being of patients with hypothyroidism, especially in the context of Pakistan. So because there was some research gap, so we thought that we should explore it a bit more. And we wanted to see how or what are the factors that are affecting the quality of life of these patients so that we can do something about it. And this relates to the objective of the study, that is to determine the prevalence of these factors, which included distress, social support, health behavior, and quality of life, and to explore the relationship between these psychosocial predictors, again with the quality of life among patients with hypothyroidism, and lastly to explore the psychosocial predictors of quality of life among patients with hypothyroidism. It was a cross-sectional study which was conducted in Rawalpindi. The participants were only patients with hypothyroidism, and the sample was recruited from visiting the hospitals that are present in Rawalpindi. Because considering the novelty of the disease, we proposed a purposive sampling technique, and we were not able to calculate the sample size. So we were only, recruiting patients who we met at the hospitals. So the inclusion criteria was patients with hypothyroidism, but we had to follow some exclusion criteria as well, depending, because of the nature of our study. So if the patient was diagnosed with a serious psychiatric disorder, we excluded them. If they had other chronic medical diseases, or if they have undergone any traumatic event in the past 6 months, they were also excluded. And pregnant women were also excluded because these factors does pose some, burden or some, effect on the quality of life of patients. So that's why these people were excluded. We use a socio-demographic form to get the basic, idea about their demographic characteristics. And other than that, we used hospital anxiety and depression scale, multidimensional scale of perceived support, social support, and quality of life WHO brief version to get data on the variables that we want this to do. So this table gives a brief overview on the demographic characteristics of our participants. Majority were females between the age range of 18 to 35, and most of the participants in our study were married. All the scales were found to have good to significant, value of reliability, which gave us the confidence that the data we are collecting will be reliable. And while exploring the prevalence, we found that majority of our participants had either clinical anxiety or clinical depression. Social support was found to be high in majority of the participants. The health behavior as reported by our participants were mostly, average, and the quality of life was again average. We were interested to explore the relationship between these different variables, and we found that anxiety and depression had negative correlation with social support, health behavior, and quality of life. So it shows that the people who have anxiety or depression will either have low social support, or they will be adopting maladaptive health behaviors, or their quality of life will be poor. And similarly, social support and health behavior again had it didn't have any significant relationship, but the quality of life and social support had again a negative a positive significant relationship, which shows that people who have social support tend to have good quality of life. And again, people who adopted good health behaviors also had good quality of life. And relating to the last, hypothesis that we had, or the objective that we had, we studied, psychosocial predictors, and we used hierarchical multiple regression analysis to do that. And we found out that anxiety and depression were significant predictors of, quality of life, along with the social support and health behavior. But among these all factors, depression was reported to be the highest predictor of quality of life, as it changes, or it contributed to 38% of the difference in the quality of life scores. So just to conclude, from our sample, 34% of the hypothyroidism patients had clinical anxiety, and 32% had clinical depression. There was a strong negative, relationship between psychological distress and quality of life. Again, social support and healthy lifestyle had a significant positive value, and the result of hierarchical regression showed that these behaviors or these factors do contribute to the quality of life, but depression is the most significant predictor of quality of life of patients with hypothyroidism. So it is very important to provide some kind of psychological help to people with who are suffering with hypothyroidism, because it can help them not only manage their disease, but it can also limit or reduce the effect of depression and anxiety that can lead to either worsening their condition, or it can lead to other chronic diseases as well. So this was basically the whole finding of our study, and we proposed that clinicians should take into account that when they see a patient with hypothyroidism, they should not only treat their physical illness, but also provide some kind of psychological first aid, or some kind of psychotherapy, so that they can also cope with or manage the depression and anxiety that comes along with these kind of diseases. So that's all from my side. I apologize if there's any confusion left, because due to the constraints of time, I try to be as precise as it could be. So if there's anything left to discuss, I'd be happy to answer any queries at the end of the session. Thank you so much.
Well, thank you very much, Ms. Medhed, for such an enlightening presentation on the psychosocial predictors and the quality of life. So, the next presenter for today's session is Mr. Mohammad Imran Marwat. Katrina, are you with us? They will gonna present on health needs. Mr. Marwat, can you hear me, please?
Am I audible to you?
Yes, you're audible. Thank you very much, Dr. Marwat. Dr. Marwat will present the paper on the health needs and the care-seeking behavior of internally displaced persons living in Jalozai camp in Khyber Pakhtunkhwa, Pakistan, a mixed method study. Over to you, Dr. Mohammad Marwat.
Sana, this screen is visible to you people?
Yes, your screen is visible. Kindly share your screen.
Okay. Is it okay now?
We are unable to see your screen.
Let me share it. Is it okay now?
We are unable to see. There is a share screen option. Yes, you have
Okay.
started. Yes.
Okay, thank you, Sanaj. Thank you, Sanaj, for inviting me for such a great event. And today I'm going to
It's
discuss.
being started. Can we wait for a while?
Sorry, ma'am.
Wait.
Yeah,
Yes,
it's shared.
yes, it's shared, ma'am.
Okay, should I start now?
Yes,
Okay.
please. Yes, please.
Okay, Bismillahirrahmanirrahim. Thank you, Sana, for inviting me, sir, for such a great event. Yesterday, I also presented one of my study findings, and today I'm going to present another part of it. Actually, these findings are based from my doctorate thesis, which I recently submitted to the Qaid-e-Azam University. I'm doing my fellow PhD Public Health. I'm fellow PhD Public Health from Health Services Academy. And this was the basically study which was conducted on IDPs. So the displaced population, what are their public health needs, and how the government responded to them after recognizing that what public health needs they required for them in such a complex emergencies. So I will start. These figures are a bit old. I will try to finish this presentation in 10 to 15 minutes time. So this is complex emergencies means there are two types of emergencies. One is called natural disasters, and the second one is man-made disasters. But whenever these both the emergencies they come together, like man-made and natural disasters, they become complex emergencies. And the main thing of this phenomena is the population from where the people are displaced. So at one point in the global, these are the global figures that around in 2018, 1970, more than 80 million people, they are living in a displacement. And out of these 80 million are here, you can say this is the 2018 figure. So 41.3 million people, they are IDPs. And the big figure is of refugees. Now there is a difference between refugees and when they cross the border of their own country or area, so they are termed as refugees, and they are governed by proper UN principles and laws. While if the people don't cross their borders, their country borders, they remain as displaced people. And you people will be shocked that still currently we don't have any national policy regarding these displaced population. Not even Pakistan, in many countries it is not over there, not present. And Pakistan is having a lot of displaced population. So there are only guiding UN agency, and since then there is no proper policy how to tackle these IDPs. And then in Pakistan, at one point, currently still more than 1.5, 1.6 million refugees are residing, and the KP province, Khyber Pakhtunkhwa province, was the worst affected from this displacement. And now this is basically this is the timeline that since the inception of Pakistan, since its creation, Pakistan is facing this phenomena. At the time of partition, around about 1 million people, they died. On the left-hand side, you can see that there were armed conflicts, and on the right side, you can see there were natural disasters. So not even in every decade, Pakistan has faced either natural disaster or man-made disaster. And then Pak-India war in 1965, and then followed by 1971, at the same time 1974 earthquake, and then 1976 floods, and then 1990s floods. So you can say not even a single decade it was free of such kind of disasters. And what happened in 2001 when America raided Afghanistan, Pakistan is having a porous border, Devran line with Afghanistan, and those militants, they crossed this border and they were settled in the agencies of Pakistan. Let me show one of this picture. This is the map of Pakistan, of those areas, of those FATA areas. Previously, they were termed as federally administered tribal areas, and recently these federal areas, they have been merged to Khyber Pakhtunkhwa district. So at one point, all the 7 agencies, all the 7 agencies starting from South, North Waziristan, and then Kurum Agency, Khyber Agency, Malakand Agency, Bachawad Agency, the whole population of these agencies, they were displaced at one point. Because due to Pakistan military operation of Zarb-e-Azab and Rahiras, etc., etc. Not only these FATA areas, even the settled districts like Swat, the people were displaced. And at one point, just in one night, more than 1.4 million people, they got displaced in 2011 and 12. So basically, this displacement phenomena, and KP was the province which was the worstly affected province. And when there was Jalozai camp, there were 3 main camps which were set by the UN agencies in collaboration with the national organizations like NDMA and VDMA. And those main 3 camps, they were located, they were situated. One was in Durrani camp, that was named Durrani, New Durrani camp, and it's in Bannu. The second one is in Hangu. And the third largest of all these 3 camps, not only over here in South Asian countries, this was the largest camp, and that was called Jalozai IDPs camp. This is the Jalozai IDPs camp picture. 2013, 14, probably. This is a very old picture, but still people are residing over there. So basically this Jalozai camp that was established in 1980s, start 1980s, when Afghan refugees were residing over here. But then in 2006, when people displaced from these agencies, the government had to settle up their own IDPs in this camp. And around about 40 to 50,000 people, they were at one point, they were residing over here. And 2012 and 13, actually, I was working as medical officer with a local organization. So at that point, it clicked in my mind that for a doctorate study, I think this could be a very good topic. And this was the main conceptual framework. Due to complex emergencies, population get displaced. And obviously, when population are displaced, they will settle somewhere in local communities or in camps, but they will need these public health. They will have all those kind of public health needs regarding their food, regarding their shelter, regarding water and sanitation, education. So all sectors, they are affected. The whole infrastructure will get disrupted, and they need all these public health needs.
Excuse me.
So basically, yes,
Excuse
please.
me, Dr. Marwan. Can you please just turn it to the presentation mode, because we are unable to read it clearly. Your presentation is very well, and I'm interested. So thank you so much.
Okay. So this was the conceptual framework, which was at the start of study. We had in our mind that what were the objectives which needs to be addressed. And the first objective was that what are the public health needs basically of these IDPs residing in Jalozai camp. Okay, and the second objective was that how the district health authority, district health department, they identified that they have such kind of public health needs and how they responded. And the third objective was that what was the response and what were the challenges faced by the local health department. And the fourth one was keeping all in the findings due to finding out these objectives, relevant data, information, and then give some kind of policy recommendations that how they could be tackled. So basically, these were the 3 objectives. And why I'm stressing upon district health department, because in 2009, if I'm not wrong, 2009 and 10, due to 18th amendment, what happened that the health was devolved to the provinces, from federal to the provinces. So at the national level, they were only coordinating at the provincial level, but they were not providing proper support. And provincial government, they were waiting because they were not ready for such kind of displacement and for such kind of complex emergencies, and how they are going to tackle, how they are going to take up with the different international and national organizations. So they were, frankly speaking, they were not prepared at all. So, and that was the main reason. Okay, and this was the main thing that around about 384 sample size was calculated, and these were basically the household heads which we decided that we are going to interview them. But at the same time, we also interviewed the family heads, and one of the married lady from the same family was also interviewed by female team members. So around about 318 male team members, they interviewed the household heads. And what were the sections in that interview regarding demography, food and nutrition, water and sanitation, and healthcare seeking practices. And the female ladies which interviewed the married couples, the married females in camps, they were related to mother and child health, family planning, and immunization. These are few of the clicks. On left upper side, I'm collecting data from the IDPs. And right side upper corner, you can see this was a focus group discussion conducted by me. And at the lower bottom, a female is conducting a focus group discussion with the female IDPs. This was the two types of data which was collected because it was a mixed study. So quantitative, qualitative data was collected. Quantitative was based upon primary data and secondary data. So IDPs were interviewed regarding their illness, their patterns, what kind of diseases are prevalent over there. And qualitative data that was also interviewed IDPs as well as the health managers which were involved with these IDPs. Focus group discussions were, and the quantitative data was put into SPSS. It was the means and the frequencies and the chi-square test right over there. Okay, yes, please.
Sorry for interrupting you. Kindly, could you please wind up your presentation?
Yeah, sure.
Thank you.
Just two slides are left. This is the one of the picture, which is showing this is health facilities, and the one person is cleaning the wound, but you can see he's cleaning the wound with bare hands. He's not having gloves. And these were a few of the findings that communicable diseases were more prevalent in these settings, then followed by non-communicable disease, waterborne diseases. And this is health seeking practices, because the main theme was that what were their health care seeking practices. So around about 45% IDPs, they decided to go outside to seek healthcare. And this was the main, you can say these were the recommendation. This was the fourth objective, that keeping in mind the health system devolution and then the public health needs of these displaced people, and the 6 building blocks they were set as a criteria that how we are going to assess. So for service delivery, we had a separate special package for them. Health workforce, separate for health workforce needed for that, and then health information system. So this was the mainly the framework which was I mean to say that was drafted in order to respond how we are going to respond to these the public health needs of these IDPs. And with this, I'm going to thank you all. Thank you so much for listening.
Thank you very much, Dr. Marwat, for giving us such a thorough review on the health needs and the care-seeking behaviors within the Khyber Pakhtunkhwa community. Well, the second presenter for today's session is Ms. Alisha from Fatma Jinnah Women University, who is the scholar of MPhil, and she will gonna present on parental knowledge, attitude, and practices towards the immunization of children. Alisha, thank you.
Thank you, Sana. Is my screen visible?
Yes.
Thank you.
And you are audible too.
Thank you.
So over to you, Alisha. Kindly switch to the presentation mode, please. And observe your timings, please.
Okay. Assalamu alaikum, everyone. My name is Alisha Pushpal, and I'm from Sociology Department, Fatma Jinnah Women University. And my research topic was parental knowledge, attitude, and practices towards immunization of children. So let's start with the brief definition of immunization. Immunization is a way to protect the children from the infectious diseases and save a lot of precious lives. Okay, let's go for a brief introduction. Immunization was introduced in the United States in the 19th century, and after the introduction of immunization, the first law on smallpox was passed. The other nations had also adopted and assimilated it into their health system. The main purpose of immunization is to prepare the children's immune system for the diseases. Immunization is one of the most health initiative intervention in the world. So SDG 3 was relatable to my research topic. The main purpose of SDG 3 goal is to ensure healthy lives and promote well-being at all age levels. Good health and well-being are just for the sake of reducing child mortality and including preventable deaths and newborn or less than 5 years age of children. It is a great news that immunization coverage in Pakistan has increased 35% in 1990 and 66% in 2018. Parental knowledge and practices regarding immunization of children are the major aspects that contribute to their vaccination decision. The main barrier regarding immunization is misinformation of parents. In Pakistan, the high concern of parents focused on immunization safety. This is my conceptual framework. Then my research objective was to assess the knowledge of parents regarding immunization of children, to measure the attitude of parents towards the immunization of children in Chakwal, to explore the practices of parents toward immunization of children. Methods and procedure. My research design was quantitative research and sample size was 243 parents. I chose CAP survey, and the locale of study was the village of district Chakwal, Chwasadansha. Analysis via software of SPSS. Okay. The sample size was 243, in which 112 was female and 112 was male and 131 was female, and age group was 20 to 35. Knowledge of parents regarding immunization. Okay, the awareness about common diseases. 14% of parents were aware about the common diseases, and they were like 29% parents were agree that immunization is safe for the lifetime, not for the certain time period, and the 22% people were like the rare disease in these days was COVID-19, and 35% parents was like immunization is safe. Attitude of parents towards immunization. 85.90% were parents were like this is beneficial for their children, and they are practicing immunization in their daily lives. And completely immunized kids were 28% and half immunized for 25%. Health team informed to the parents about their immunization, about the kids' immunization dates, 30%. And the minor side effects of immunization was 17%. Discussion. The result shows that respondents were aware about the common diseases. Parents said that the immunization is safe and effective, and the only way to prevent the infectious diseases. Parental knowledge is very important in the practice of immunization of children. Parental knowledge has significantly influence on immunization of children, and immunization is beneficial. Parental knowledge is a way to improve the practices of parents regarding immunization, and it is a way to change the perception of parents. Conclusion, it is concluded that as the previous study shows that in the previous few decades, Pakistan has faced the crisis of immunization. Parents of Chausadan Shah were knowledgeable about the immunization, and they were they are also practicing immunization, and a majority of the children were completely immunized. Parental knowledge regarding immunization influence on the children immunization, and parents are willing for the immunization, and parents are actively practices the children immunization. Recommendation: entry checks of children immunization at school level. It is very important to increase the ratio of childhood immunization. Non-immunized children should not register in the school for the admission, and the children who have not done their immunization at the right age should not allow them to join school at the early age. Government should arrange different and informative campaigns for the parents regarding immunization, and financial incentives should provide to the parents and healthcare team to increase the demands for immunization. Thank you so much.